I hope everybody can see my screen and my presentation. And thank you for the meeting organizers for inviting me to present today. And I apologize for not being able to be there with you in person to present. So I'll be presenting on the strategies for hepatitis B and hepatitis C elimination in the United States. I will first start my presentation by highlighting the US national strategy for viral hepatitis elimination, and then moving to some of the strategies that have been implemented in the US to move towards the elimination of hepatitis B and hepatitis C. So the US National Viral Hepatitis Strategic Plan, the latest one, the current one, has 5 main goals, mainly preventing new viral hepatitis infections, improving health outcomes for people with viral hepatitis, reducing health disparities, improving surveillance and data usage, and also achieving an integrated and coordinated efforts to address the viral hepatitis epidemic across multiple partners and stakeholders in the country. In order to track the achievement of hepatitis B and hepatitis C elimination, but also include hepatitis A in there, elimination in the US, there is 8 main core indicators that are monitored on an annual basis and to track the achievement of specific targets. We have 5-year targets, which end in 2025, and 10-year targets, which end in 2030. So that's compared to 2020. And each target, basically, the main targets are reducing the acute infection by a certain percentage, increasing birth dose vaccination, increasing the proportion of persons with hepatitis B who are aware of their infection, reducing the death due to hepatitis B and hepatitis C, and also increasing the proportion of people with hepatitis C who have cleared their infection. Some of the targets follow the global targets, but also some of them are way below the global targets. And in addition to these targets, we have also some targets that address health disparities and people disproportionately impacted by viral hepatitis in the United States. Now, moving to the strategies for achieving elimination for hepatitis B, one of the key strategies is hepatitis B vaccination. And there's been a lot of changes in the US around hepatitis B vaccination recommendations and using data to inform these changes and recommendations. Just as a background, there are an estimated 660,000 people with hepatitis B in the US based on our national sero survey estimates. But there are also some modeled estimates which estimate that the number of people with hepatitis B could be up to 2.4 million. Now, the epidemiology of hepatitis B in the US is basically it's a tale of 2 epidemiologies. The chronic infections, like 75% of chronic infections in the US, were among persons who were born outside the United States. And the figure that is shown here, which shows by age group, across all age groups, the blue lines are the number of infections among immigrant populations, and the red lines are the total number of infections by age groups. So obviously, in all these age groups, over 70% of the infections are among people born outside the US. Whereas the acute infections are more locally acquired, and this is mostly among people who are unvaccinated, who have certain behavioral risk factors that put them at risk of infection. So to address the chronic hepatitis epidemic in the US, but also the acute cases of hepatitis B in the US, the vaccination recommendations have been changing over time. So over the past 4 decades, first, it started in the 1980s by just targeting people at higher risk of getting infected with hepatitis B. And also infants born to mothers who were positive for hepatitis B surface antigen. So these were the first 2 groups that were targeted. And if you see this blue line in this graph, this is the number of acute infections. So after these 2 recommendations were implemented, there was a significant drop in the number of acute infections in the US. And that's based on our national surveillance data. And then in 1991, a recommendation was expanded to vaccinate all children or infants for hepatitis B with 3 doses of hepatitis B vaccine. The birth dose vaccination was still selective at that time. So it was only still targeting children born to mothers who were positive for hepatitis B. And then in 1999, there was actually catch-up vaccination of adolescents, which was implemented. So any persons who were not vaccinated in the past were started to be vaccinated between 0 and 18 years. And then it wasn't until 2005 that universal birth dose vaccination recommendations were implemented. So that every child, irrespective of the mother's hepatitis B status, is given a birth dose. So that's in 2005. So you see, across all these recommendations, it led to a significant drop in the number of acute cases of hepatitis B. Now, in 2011, that's when more like the adult vaccination recommendations started to come into attention. We noticed an increase in persons who have diabetes who were getting acute infections with hepatitis B, and that was happening across multiple states in the country. An investigation of these outbreaks highlighted that the main reason for these infections among patients with diabetes were basically they were tested using blood glucose monitoring devices, and sometimes these devices were shared between patients. And these devices had like some small amount of blood, which is not visible to the eye, but it was still there. And an analysis of the virus showed that these all shared the same virus, so it was transmitted from a common source. So as a result of this, there were vaccination recommendations which were put for all the persons with diabetes younger than 59 to receive the hepatitis B vaccine. So as a result of the successful childhood vaccination program, the United States has actually achieved the impact target for elimination for hepatitis B, measured by hepatitis B surface antigen prevalence, and that's based on nationwide serosurvey data. So, and this has been occurring since 1999. So since 1999, the prevalence has been less than 0.1% in children. And in the latest survey, none of the cases tested, none of the survey participants in that age group tested positive for hepatitis B surface antigen. Similarly, we have data from our perinatal hepatitis B prevention program, which tracks the infection among infants born to mothers who are surface antigen positive. They track their vaccination status, and also they test them after vaccination to make sure that they are protected or if they are infected. So also the US have achieved the mother-child transmission elimination goal of less than 2% since 2009. So this has been also achieved. However, when we look at the vaccination among adults, because it was still risk-based recommendations back in before 2022, the coverage was still low. So and when we look at our acute surveillance data, we see that the infection rates, basically the acute infection rates among adults, has been increasing among those, especially those older than 40. So, and because it's a risk-based vaccination, we always look at risk factors of acute infection. And unfortunately, only 33% of persons with acute hepatitis B reported a risk factor. So the majority did not report a risk factor. So obviously, risk-based vaccination wasn't working. So as a result, in 2022, the Advisory Committee for Immunization Practices recommended that all adults aged 19 to 59 years should receive hepatitis B vaccine, and adults over 60 with risk factors for hepatitis B should also receive the hepatitis B vaccine. Now, adults over 60 without known risk factors, they may receive the vaccine. This was a lower kind of category of recommendations because we know that with age, the immune response to vaccination gets lower. So if a patient or the healthcare worker, healthcare provider thinks that this person should be vaccinated, they can get vaccinated, but it's not a strong recommendation. So in addition to vaccination recommendations for prevention, one of the important strategy to actually diagnose people with hepatitis B and hepatitis C and link them to care is actually making sure that they are screened and tested to identify them. So in the United States, we use both epidemiological data and cost effectiveness analysis data to inform our screening and testing recommendations. So, for example, for hepatitis B, looking at the rates of newly reported chronic hepatitis B infections per 100,000 population in 2023, we noticed that the rates of infection start to increase significantly after the age of 20 years. So obviously, this is coming across multiple age groups. Similarly, mortality also started to increase after the age of 30 years. And we know based on our national survey data that only 50% of persons with hepatitis B were aware of their infection. So obviously something needs to be done about the screening recommendations. So I will go through how the changes in the screening recommendations occurred over time in the US. So first, the screening recommendations were mainly focused on healthcare workers, persons who work in public safety, and also blood donors and tissue donors and others. And then HIV testing, also persons with HIV started to get recommendations for screening, pregnant women and their infants, and then risk-based vaccination testing across, basically persons who have certain behaviors, but also persons on hemodialysis and others, and household contacts. It wasn't until 2023 where we recommended screening for all adults age 18 years and older. And this is based on the data that I showed you for our chronic infections in the US and the low awareness of infection. So all adults now in the United States are recommended to be tested at least once in their lifetime for hepatitis B. We recommend using a 3-test panel, not only surface antigen, but also anti-HBs and total anti-HB core because of the universal hepatitis B vaccination recommendations, so that we can identify people who are susceptible and should be vaccinated as well immediately. The remaining recommendations are unchanged, so still pregnant women are getting screened, people with history of risk factors are getting screened, and people who are ongoing risk factors are getting screened on a periodic basis. So for hepatitis C, it's the same situation as hepatitis B. Just to also for your awareness, the hepatitis C prevalence in the US is much higher than hepatitis B. So because of the opioid epidemic, we have an estimated 2 million people living with hepatitis C in the US, and some estimates go up to 4.7 million people with hepatitis C in the US. So it is a much bigger epidemic. And also here we see the chronic infection rates start to get higher after the age of 20. Here we have a higher percentage of people with hepatitis C who are aware of infection compared to hepatitis B. So 68% of people were aware of their infection. However, similar to hepatitis B, only 17% here of acute cases of hepatitis C have an identifiable risk factor. So that's where basing our recommendations on risk factor wasn't working, because most of the patients are not identifying the risk factor. All the physicians are not asking their patients for any risk factor. So similar to the hepatitis B screening recommendations, the recommendation in the US actually changed over time as a result of all these data, which is first starting with more like targeting specific groups, risk-based testing. And in 2022, that's when the first kind of more extensive recommendations started to be implemented. It was recommended to have a one-time testing for each person born during 1945 to 1965, regardless of risk. And the reason for that is that epidemiological data show that the persons born during these years have had higher rate of chronic hepatitis C infection. And the reason for that, this is referred more at the baby boomer generation. Many of them have used drugs maybe in their youth, and they reach an adult age, and they probably would not disclose this kind of information to their healthcare providers. So just testing everyone, irrespective of risk, would kind of identify most of the people living with hepatitis C in that population. And then in 2020, because we saw that risk-based recommendations were not working, we recommended more extensive screening of every adult at least once in their lifetime, screening every pregnant woman during each pregnancy, and every one of the risk factors on a regular basis. And in 2023, the perinatal hepatitis C screening recommendations also were expanded, where hepatitis C screening, in addition to testing pregnant women, testing also their babies with HCV RNA at the age of 2 to 6 months, so that they can be directly linked to management and care with a pediatric hepatologist. And one area I would like to highlight also that also in 2023, there was a CDC recommendation to implement automatic HCV RNA testing on all HCV antibody reactive samples. This is called reflex testing. And the reason for that is to basically avoid this loss to follow-up between anti-HCV tests and HCV RNA tests. And yesterday I heard during some of the presentation that this was a main kind of concern across many other countries. So the CDC made this recommendation basically to avoid this loss to follow-up. So at the same time where somebody is tested for anti-HCV, a blood specimen is getting collected for reflex HCV RNA testing to avoid this loss to follow-up and immediate diagnosis. And currently, actually, the CDC is also looking at data to recommend viral first testing. So basically avoiding the anti-HCV test and moving directly to HCV RNA test. This way, the person will be diagnosed immediately and immediately linked to care as well. So we're working on the economic assessments and assessment for this recommendation. So why universal testing and screening for hepatitis B and hepatitis C? Obviously, risk-based testing had limited success. These infections, if diagnosed early, can lead to reduced morbidity and mortality. And for hepatitis C, they can lead to cure as well. And cost-effectiveness study in the United States have shown that these recommendations were cost-effective. So this would help us achieve elimination goals faster. I will just dwell quickly on the expansion of hepatitis C treatment recommendations because of the high burden in the US. Despite the availability of very effective direct-acting antivirals since, the mid-2010, 2014, 6 years later, an analysis done in 2019, 2020 showed that over 65% of persons with a diagnosed chronic hepatitis C infection were not being treated. And the main reason for that is the insurance, and that's irrespective whether it's a public or private healthcare insurance. And this is the reason why, because these insurance companies had restrictions on and pre-authorization requirements. So one of the interventions that were implemented is removing these eligibility restriction and pre-authorization requirements. And this is based on a state-by-state level. So many of the states have removed this recommendation. So some of the strategies that were implemented to scale up screening and treatment for hepatitis C include decentralization and integration of hepatitis C testing and treatment within primary healthcare, community clinic, correctional facilities or prisons. That was a big actually intervention implemented, as well as pharmacies who were allowed to screen and provide treatments. Integration of hepatitis C within harm reduction and infectious disease testing and treatment services as well help to reach people who inject drugs, and then making the medications more affordable for all the populations. So actually this figure that I have here shows some of the successful models that were implemented in the US. Now, these recommendations are, useless if people don't know about them. So the way we actually disseminate this kind of information, we target both the general population. So by working through community-based organizations, we use multiple languages to target people across multiple communities in the US to highlight the importance of hepatitis B and hepatitis C screening and treatment and prevention. Similarly, for healthcare workers, we work with the universities. Here we have University of Washington. There's available free continuing medical education that are available online. People can access them anytime. I suspect they can be accessed from any country in the world where people can learn more about hepatitis B and hepatitis C. And also CDC recommendations available on a regular basis are disseminated through various channels. So in conclusion, in the United States, we use epidemiologic, economic, and clinical data to develop hepatitis B and hepatitis C prevention, testing, and treatment recommendations. Vaccination and screening strategies have evolved throughout the years, while risk-based strategies have moved the needle, but they were not enough to get the job done. So the shifting epidemiology and the cost-effectiveness analysis have supported the universal screening and vaccination recommendations among adults. However, these recommendations are only a starting point. So more work is needed to achieve viral hepatitis elimination goals, including making sure these recommendations are disseminated and implemented, but also making sure prevention, testing, and treatment services are available where people living with hepatitis B and hepatitis C seek care. Thank you.